severely communicate fractures, about 15% of cases require surgical treatment either in the form of tense snelling or the internal open reduction and internal fixation with plating. So let us come to our main topic, that is tense snelling is unlike conservative management. It provides stable fixation and early mobilization and reduces the risk of non-union and malunion. Tense is less invasive, resulting in a smaller incision, reduced soft tissue damage, and fewer potential complications, making it an attractive option for managing displaced fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, or were simple displaced fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nerve in my hospital. So the mode of trauma, no traffic accident was the main mode of the trauma, whereas fall from height and fall on out the state side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI. And this is a typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin. And this is the radiological typical presentation, more than 2.5 centimeter displacement, and the dead type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and a screw. So these are the already explained. The simple fracture were taken into consideration. Displaced simple fractures either spiral or oblique or transverse or short oblique, 15B1 and B2. The patient lies supine on the affected lip, elevated, and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed means. The incision, small incision, and a transverse or longitudinal incision about 1 to 1.5 centimeters, just lateral to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense snelling after close reduction or mini incision reduction. So the immediate course of pain management and immobilization, after 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, and 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite-out, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nerve, beautiful surgery without the use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, yet another case of the 15B1 fracture treated by titanium elastic nerve. Yet another case of 15B1 fracture treated by titanium elastic nerve. These are the 15B2 fracture. This is 15B3 fracture treated by titanium elastic nerve. Ideally, it should be treated by open reduction and internal fixation, but we did tense snelling, and you can see that 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see. So the time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up period and retrospective design. So a study with large number of population and long duration of follow-up and prospective study is required to establish this modality of treatment as an attractive option for the treatment of displaced fracture of the take-home message is TENS nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further studies are needed to confirm the long-term efficacy of this. This work published in International Journal of Orthopedic Science.
अगर रोज 5 घंटे रील्स देखने की जगह सिर्फ 15 मिनट एआई सीख लो तो अगले साल तक आप भी अर्निंग शुरू कर दोगे। जरा सोचो, 5 घंटे रोज प्रिय साल।
17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity, and inability to bear the weight on the right side, whereas the left side he had a Gallagher fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex forearm fracture and dislocation, which we call the Gallagher fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture. And the slight distraction, the TENS nailing for Gallagher fracture, and this is not reported in any literature for the such a severely displaced fracture. The TENS nailing should be considered. In fact, there is no literature present for the TENS nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture. But we did locking, it was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive. And whereas in this left radius, the Gallagher fracture, we did TENS nailing. In this case also, the 2 millimeter TENS nail was used. Usually you use a 2.5 millimeter TENS nail, but we use 2 millimeter TENS nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. But this is the 6-month follow-up. You can see I sent this X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see. So after waiting 11 months, the union is complete in both the fracture. The secondary colors have been formed. It was not hypertrophic non-union. It was the union, secondary union was taking place, although it was delayed union, but this is the functional result. You can see that supination, pronation, and wrist movement, flexion and extension all are present, and the tense swelling is provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained to and DR UJ should be reduced properly. We followed the throughout 11 months for this maintenance of the length and DR maintenance. And advantages of this minimally invasive approach for Gallagher fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fractures case confirmed that interlocking nailing of femur and TENS yields higher union rates and excellent functional outcomes. This approach should be considered for Gallagher fracture in adult after further studies, because I think this is the first case in severe Gallagher fracture. I did TENS. So this case was published in International Journal of Orthopedic Sciences.
मैं महीनों से एक YouTube क्रिएटर के रूप में वीडियो बना रही हूँ, लेकिन ना 1000 सब्सक्राइबर पूरे हो रहे हैं, ना 4000 वॉच आवर्स, और बिना मोनेटाइजेशन चैनल से कमाई कैसे शुरू होगी? फिर मुझे मिला UCO, अल्टीमेट YouTube क्रिएटर टूलकिट। इसने मुझे दिखाए सही वीडियो ट्रेंड्स, मेरे पुराने वीडियो के SEO फिक्स किए और सही कीवर्ड्स बताए, जिससे मेरे वीडियो सही ऑडियंस तक पहुंचने लगे। UCO की मदद से मेरे चैनल
provides stable fixation and earlier mobilization and reduces the risk of non-union and malunion. TENS is less invasive, resulting in smaller incision. Conducted a study between March 2020 to March 2025 on 25 cases of the displaced fracture of the clavicle. The age of the patient was 16 to 48 years, and no comorbidity was found in our study group. All patients treated with titanium elastic nylon. So the road traffic accident was the main mode of the trauma, whereas the fall from height and the fall on the outstretched hand was the other mode of the trauma. So the typical mode of the trauma, this picture is taken from the AI, and this is the fall on the shoulder to protect the head injury in mode of trauma. And this is the typical presentation, a bump at the fracture site, and the skin appears as if the skin will penetrate the fragment will penetrate the skin. So, and this is the typical radiological picture. You can see the severely displaced fracture, more than 2.5 centimeter, a jet type of fracture, that type of comminuted fracture, and the other indication for surgical treatment is the floating shoulder. So these are the typical presentation as well as the radiological presentation and the mode of the injury. And we included the simple fracture only, 15B1 and 15B2 according to AO classification. The 15B1 is a spiral and oblique, whereas 15B2 is the transverse and short of the fracture. So the patient lies supine with affected limb elevated and hanging outside the table, so that the reduction can be done by doing abduction and external rotation of the shoulder. So incision, there is 1.5 centimeter lateral to the sternoclavicular joint, and after making incision, we make a hole with the help of the drill bit or the bone out. But this is a crucial step. One should be very, very cautious, because the heart and the lungs are like vital structures are waiting for your instruments to escape. So this is a very crucial step, and then make this hole continuous with the intramedullary canal of the clavicle, and then we did close reduction or mini incision reduction, and then titanium elastic nailing was done after reduction of the fracture. So the post-op protocol or immediate post-op, we did pain management and immobilization of the limb. After 2 weeks, the wound inspection and the suture removal. At the 6th week, the radiological follow-up for the fracture healing, and by 12 weeks, the functional assessment of the fracture healing, and finally the superficial infection and malunion. Each had 4% figure, and the hardware irritation was 8% in all our cases. These are few cases. The radiological as well as clinical picture, as you can see, this is 15B1 fracture, treated by titanium elastic nail, the post-operative case, and the beautiful surgery has been done. You can see the one stitch surgery, no instrument was mid-third fracture treated by titanium elastic nailing. Yet another case, 15B1 fracture treated by titanium elastic nailing. Yet another case of 15B2 fracture treated by titanium elastic nailing. And this is again 15B2 fracture treated by titanium elastic nailing. And this is 15B3 fracture. Ideally, it should be treated vocal reduction and internal fixation with the plate and screw. But we did titanium elastic nailing in this case also, and you can see that the beautiful union of the fractures at the 6 month follow-up period. So this is the functional result. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here.
I'm just lazy. What is actually happening is your brain is protecting you from perceived threats. I lack discipline. What is actually happening?
ये फ्रैक्चर है टिबिया का, कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापेटनल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैलिएबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। एक उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। Finally, lower end of the medullary canal तक डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है RCT नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सी आर्म के मदद से गोल करने के बाद, होल को गोल करने के बाद इस तरह से सी आर्म को एडजस्ट किया जाता है कि होल गोल दिखे, और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल, और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है, अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। फाइनली दोनों स्क्रू को, उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को, और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सी आर्म को एडजस्ट किया जाता है कि वो गोल दिखे, और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है, जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सी आर्म को एडजस्ट किया गया है, और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है, और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू लोअर फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए, छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैगमेंट फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये RCT नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, In the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the sharp femur. So this time the patient had come to me for the lower third fracture of the sharp femur or other limb. So let us come to the surgery. An incision just above the trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a just medial to the greater trochanter in the pipe of fossa in AP2. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior to
हो गए हमने सीख कर
ऑपरेशन
वो भाई तो सुन रहे हैं कैसे पकड़ाते हैं इनके सारे पट्टू बा देखो पकड़ ले लो बढ़िया से गिलावा था वो तो दोस्त नहीं कर रहा घाव में दोस्त मेरा असिस्टेंट चलो चिपका और सब पहना दिए हम स्टार्ट ले दिए अभी चेंज लेके भर दिया देखो पीठ में गाँव हो यही खातिर कर जाना अपने पीठ में गाँव होकर शुरू हो गई बैठते जाऊँगे उठावे ना नहीं कम से कम बैठे जाऊँ उठते एक दिन बैठा रहा बैठा तो नहीं उठते कहेंगे बैठा तो कर परिवार क्या जाने बैठा तो नहीं हो एक दिन तो बैठा रही देखो
ना हम रातों में बैठो तो
पर लड़का के लिए
लड़का के
बाहर
हाँ
ठीक बोला तो और भी ज्यादा हो गए पर लड़का के बैठे चली घरों पर
ला दिए यही पे
कमर उठाई ना अब सीधा होके छोड़ दिया सीधा होके
सीधा
अपने
हाथ छोड़ेंगे तो
पकड़
बेटा कमर उठा सकेंगे होगा बस तो और बोलो बस हो गए
बैंडेज को बैंडेज
हाँ बैंडेज हो गया
खाए हुए की बता दो
सब बता दो ठीक से बांधिए आदमी ऐसा उठा करे तो नीचे से बांध दिया
और खाते रही
हम कर दिखाइए
दवाई लिख दिया ठीक हो जाएगा
दवाई
और देखा करेंगे
को पछुआ करता है
हाँ तो भैया ऐसी बात भैया कुछ लगा दो तकिया किया हाँ ये तकिया लगा दो
तब ये बात
अगर ले
वहाँ करते थे मांगेगा
हाँ वाटर ले Anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am hammering the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and epi view. This is the lateral view. This is the epi view. And this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR. And you can see that this is the epi view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3 at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral.
If you are running a business where you are the one who's managing operations, sales, marketing, finance.
Provides stable fixation and earlier mobilization and reduces the risk of non-union and mal-union. Hence, is less invasive, resulting in smaller incision